Did you want to respond to that, Mr. Norman, or not? Couldn't tell.
No, I think we're going to go in circles. I think it's clear where our position is, and I think it's clear where their position is. I think the desire of hospitals to be able to buy medical practices is clearly an issue with regards to business model and profit driven. We think that's inappropriate, but we'll go around in circles.
Yeah. No.
And if I could also just ask, just because this was stated a couple of times, so CMA, you're saying you remove your opposition if this amendment is accepted?
We've never made that statement, ma'am.
Okay. Just checking.
What we've said is, and this is true even in our negotiations and dealings with 1306, is we have three issues, right? The committee is suggesting that of those three issues, one of them is clearly, we've made the case, or the case has been made. There's consistency issues with regards to the actions of this committee, and that one has been put forth. We've been having that discussion on that one. We think some level of physician involvement, like we did for the podiatrists, like we did for the dental surgeons, makes sense. We think also ensuring that that all the other patient protections, that if you're going to do, essentially our position is, and we've had the same discussion, if you're going to do the same job as a physician, if you are going to practice medicine, then you should abide by the same rules that the physicians of California practice under. Until you're willing to do that, we're not willing to remove our opposition.
Okay, Mr. Wilk has a question.
Thank you, Madam Chair. I apologize because I didn't write down your name, but the local pediatrician that spoke, yes, sir, if you could come up. And while he's coming up, just to kind of kill time, I think we're all grappling with providing access to care and patient safety, and I think that's where kind of the crux of this. So I just wanted to follow up on your earlier testimony. You were citing, I think, maybe a study in Arizona where they tried to expand primary care access through broadening the scope of nurse practitioners, and you said it failed. I was just wondering if you could elaborate more on that.
I didn't bring that study in, and I don't have the reference right here. That's information we can get to you. I think you do have to look at states where what you're considering doing has happened, and see what happened. And my understanding of that experiment in Arizona was that access to primary care, did not see a significant expansion. There have been other examples of that. I think some of the member Wood pointed that out in his area, whereas they thought there would be expansion of care. In fact, they really haven't seen it. And my belief is that this bill, because of the makeup of California and the laws and regulations that California practitioners are under, I think the hope that primary care access will significantly expand is way over optimistic.
So I have a follow-up then, if I could.
And I'd like to respond.
If this were to pass, do you see any law of unintended consequences if this were to pass? Or you think it doesn't matter, or what?
Well, I'm speaking specifically to access. I just do not think that, other than small examples in a very big picture, you're not going to get much bang for the buck in access as a consequence of this bill.
But that's an opinion, correct? I mean,
that is my opinion.
Yeah.
And if I could just make one comment. I mean, life is about choices, right? Nurse practitioners, under the current statutory model, they don't have the choice to go practice somewhere where a physician is not, because they are tethered. So, you know, we can all speculate about all this, but until we remove that tether.
I'm just going to, because I've heard so much about this bill, I have to make sure they can go practice many miles away from their supervising physician currently, and that's happening in clinics all over the place. So I'm not arguing, but they are tethered by the standards and the procedures, but they are not physically tethered currently.
Correct.
So. Yeah, I just want to.
I appreciate that clarification, but they have to find a physician who is willing to supervise
exactly,
them
and the physician is
which
limited to 4. Yeah, that they can supervise. Yes.
So I'd like to respond to Assemblymember Wilk's question and the Arizona issue. I have a study that I read 2 years ago, and I can't reference it exactly, but the gist of it was, and I can have my staff look up, is that when Arizona passed their nurse practitioners, one of the most expansive in the state of California, in the state of Arizona. one of the more liberal ones. And upon its enactment, they actually had an increase of nurse practitioners who went to that state who were graduating from surrounding schools and colleges because there was an opportunity for them to practice at a much higher level. And that's very similar in other professions. But also, from my memory, is they did look at where the distribution was, and there was a concern to that question, and they broke it down to city, inner city, rural, but even rural. And there was a net increase in the rural and rural within those providers. Now, is this going to solve the entire problem? No. This is a small part of the solution, along with pharmacists, along with how we're going to increase rates, how we're going to build more medical. This is just part of the overall conversation. And to Christy's comments, is there going to be an influx? I don't know. But right now, the way it is, and yes, they have the ability to go further away, but they have to have an understanding with a physician. And a lot of those physicians may choose not to bring on additional nurse, and they max out at a number of 4. So this could potentially increase job opportunities, more individuals to come into the state, and choose different modes of practice of how they're going to. But without that opportunity, we won't find that out.
Thank you. Mr. Wood.
Yeah, my question, I have to think how I want to word this. I heard from the nurse practitioner from the Russian River area that part of the advantage was savings. The ability to provide care would provide a savings in keeping people from an emergency room. Appreciate that, and very much appreciate that. But I also heard something in there that is probably a lot of the crux of the issue here that I don't think has really gotten enough play, and that is the protocols and the ability or the challenges that nurse practitioners have in getting changes to those protocols. So my question is, to the authors, had you considered, have you considered that? Because I still think that the number of nurse practitioners who will ultimately potentially take advantage of this will be fairly small. However, an expedited way to changing the protocols, to working through those, to getting more buy-in, to keep that team-based environment going, seems to be a step that we've kind of leapfrogged over here, and we've just gone to this next level. So did you look at a mechanism that might help to deal with the protocols? Because I just feel like that's a missing part of the conversation.
To your question, in the past, our association has worked with a number of members of the legislature to try to do bills that take that approach that you've described to modify the standardized procedures. And they were always faced with, quite frankly, the same type of opposition from the physicians that we have today. So,
Mr. Gatto.
So thank you. This has been a very, very thorough hearing. I don't think the corporate practice is the fundamental part of this bill. I think it's important, but I am, because we've talked so much about it, I'm trying to wrap my head around it. And this year, I'm new to BNP. This is my first year on the committee, but this year we approved, or we reaffirmed the corporate practice ban for optometrists. We approved a bill that the chair negotiated that had a corporate practice ban for nurse midwives. And I'm just trying to understand why nurse practitioners are special, or why they deserve special treatment.
I don't think we're suggesting that nurse practitioners deserve special treatment. That's not what we're suggesting here. I don't know if you were here when the representatives from the Children's Hospital, the challenge for nurse practitioners is since they have existed in California, they have been employees of hospitals. If we subject them to the corporate bar, they can no longer be employees of hospitals. So that does two things. One, it would seriously disrupt patient care, because if you have nurse practitioners who are in those roles at hospitals and they're providing patient care, and then they can no longer do that, that's bad for patients.
I have to clarify again, that's for those who choose to be independent. They
That's
could
correct.
continue their employment in hospitals as today. Mm-hmm. There would be no negative impact on their employment.
So for the nurse practitioners, Chair is correct, that we're talking about here, That's what the reality would be for them. And yes, they would then become independent contractors. They could contract with the hospital. Being an independent contractor is not an uncomplicated thing in California. There's a whole lot of complexity that comes along with that. And they would lose the protections that they currently have as employees of those hospitals.
Which is a choice. All right. I think we've actually exhausted everybody. I was going to say exhausted their questions. Literally true. I have a few more comments, so I just wanted to kind of summarize where I was trying to get this bill and whether that's the right place or not. Don't know where my colleagues will be on it, but was trying to balance the concerns we've heard as we move a profession from a supervised to independent standard of applying the same rules to them. Did feel again, though, that some of the other amendments that have been discussed today weren't necessary. The business arrangement. I really believe this bill has achieved integration, and I think that is the ideal way. 2 years ago when we heard the bill, we talked a lot about the fact that in an integrated setting, nurse practitioners are functioning very, very well independently of supervision. And I think that we are moving with ACA towards very patient-focused integrated models. Don't agree with CMA on the fact that some of these business models aren't integrated enough. I think we're going to get there on that one. Don't think we need to put it into statute, and we should allow the freedom of the business models to evolve and develop without locking something into statute. And that was very important to CAPCHE, which is an organization that has a lot of physicians who actually happen to be members of CMA, are members of CAPCHE. That's what they really want. And I thought that was very important, flexibility, and nothing that was going to be a negative impact on consumers. Also, we know the chair took the self-referral anti-kickback provision, which was very important as well. I think that the issue of the medical board oversight, I already gave you my opinion on that. I think we just open up a can of worms if we start having the medical board basically get to sit on every other board that is in the field of nursing or medicine, and there's a reason we have our separate boards. And that really leaves us, and the peer review, they accepted that as well. It really does leave us with the issue of the corporate practice of medicine bar, and feel that that is something that remains important. I do think that personally I wouldn't mind having a little more time to see if we can't hammer out an agreement, but that would be an agreement that everyone would have to participate in. It's certainly not something that is just a one-sided agreement. It would need to be something where I feel the committee said let's have another week where maybe we can actually get down to brass tacks of the business here and see if we can't come to something that is workable. So that's my hope right now at this point. Don't know where the committee will end up, on the issue. So with that, ask you to close.
Yeah, so I was on this committee last year when we heard this bill, and some people were here, some people weren't. But when we were sitting here, I was actively taking care of my sister-in-law who had been diagnosed with cancer and died within a short 2-month period of time. And partly she had no health care insurance. She didn't have access to health care. Her only access was in through the emergency room. And I can tell you that was an incredibly painful process that I'm not saying it would have been averted, but it could have potentially been averted and she had seen nurse practitioners in other systems when she had insurance before. So it was very real to me in that time, which is why I agreed to do this bill this year with Senator Hernandez. And people know I've been a long-time healthcare practitioner, worked in and around the Medical Association as well as with a lot of nurses and physicians. I think this continues to move the ball forward with access, and I think we don't have any evidence that patient care is compromised. It seems to me the one real thing we're arguing about right now is the issue of the corporate ban. And as Mr. Mullen asked about the politics of the possible, I think it's very clear that you have multiple sides. And trying to move something good, I mean, you've got the hospital industry, you've got the CMA, right? So who do you want not to be with you. And I'm not saying that we should ever have to choose, but when it comes down to it, sometimes you have to try to find a way to find that middle ground, to thread that needle for the good of many of our communities who are tragically, medically underserved. And so it seems to me that for the most part, people agree that nurse practitioners, in their scope that they're already trained for, in their scope that they already practice in, that we all seem to agree that is probably a good thing, that we need to move it forward. And the crux is this issue of the corporate ban. So what we've already said, we're not talking about a huge population. It really is, should nurse practitioners who choose to be independent be able to be a hospital employee? That's what we're talking about. It is a very simple, small thing. So I respectfully ask for your aye vote as we continue to keep this moving forward, and my commitment to keep on working on this issue.
Thank you.
Thank you, Madam Chair and members. Again, I'd like to thank Councilmember Eggman, of course, you, Chair, for all the work and time you've put into this issue. And yes, this is a difficult issue. And yes, I do bring difficult issues up. But I've said this before, if I don't, well, if I can't make a difference in the state of California, then I shouldn't be here. And by making a difference means you bring up difficult issues. That's why they elected us.
Yes.
And I have no problem losing a bill either, because this is what I believe in. So going back to the body of work that we did, we all agree there's a capacity issue. There is a distribution issue. There is a reimbursement issue. There is a lack of primary care physicians that are going to those areas and going into primary care. Is this a solution? This is part of the solution, along with all the other changes that we have to have those conversations, whether it's reimbursement rates, Medi-Cal, looking at loan repayment, to your issue with regard to the rural areas. I was on that bill 4, 5, 6 years ago in the Assembly, the same opposition to exempt rural hospitals to hire physicians. And there was the same opposition from the California Medical Association. When we've tried to do nurse practitioner bills to do any kind of change of standard protocol, there's the same opposition. And what we're hearing for the first time is willing to work, but it's on the corporate ban. But I didn't hear that they would remove their opposition. So I have to choose, okay, with no commitment to remove their opposition, then I'm going to lose all of my supporters. It just does not make sense for me politically to go down that route. So this bill has been whittled down significantly where it's dealing with, and I understand the need, believe me, for coordinated care. That's where we're moving. Medical homes, patient-centered medical homes. This bill is specific to allow them to do that within those particular settings. And if we change that, then you're going to allow the entrepreneurship of individuals to start moving into those various areas and, yes, maybe make a difference in your rural areas, in the inner city. So, I think the only thing I can be guilty of is bringing a tough bill, and I apologize for that. And, Mr. Dodd, I hope I'm the last guy you heard today.
Well, seeing as how I'm the chair.
The last testimony. And members, you've got to bring a little brevity, because at the end of the day, I'll tell you, there's things we're going to work on.
Yes.
Medi-Cal reimbursement rates, we all agree. I'm going to be as outspoken as we possibly can. But you know what? I believe that this is going to make a difference in the state of California, and I believe I'm going to be outspoken in this as well. And Madam Chair and members, I respectfully ask for an aye vote. Thank you.
Thank you very much. And you brought up the rural hospital issue, and I think that there are notes in the analysis as well, because that's a issue I'm very aware of that certainly that needs to be addressed in any considerations. So with that, we'll go ahead and take the vote. And we have a motion, I hope. Do we? We need a motion.
I'll move the item.
Second?
And just for clarification, you are it's a due pass with the amendments that you accepted, not the amendment on the corporate bar, to appropriations, and that included the intent language amendment. Thank you.
Bonilla?
No.
Bonilla, no. Jones? Baker?
No.
Baker, no. Bloom? Bloom not voting. Campos? Campos, no. Chang?
No.
Chang, no. Dodd?
Yes.
Dodd, aye. Eggman?
Aye.
Eggman, aye. Gatto? Gatto, no. Holden? No. Holden, no. Mullen? No. Mullen, no. Ting? Aye. Ting, aye. Wilk?
Aye.
Wilk, aye. Wood? No. Wood, no.
Four to eight, the measure fails.
Okay, thank you very much. I do have another bill.
Yes,
It's
and
very
I'd like
controversial.
can we grant? Yeah, and can we grant reconsideration on the NP
Yes,
bill?
I'd like reconsideration, Madam
Thank you.
Chair, members. Thank you very much.
Oh, someone's knocking.
Shall I
We
proceed?
moved the bill, and we had a second.
I respectfully ask for an aye vote.
But we have some people who want to get up here at least.
Wait, we have opposition.
We do have opposition.
Oh,
We're
you're
removing it.
Oh, are you removing it? Yes. Okay, then I respectfully ask for an aye vote.
Okay. We should state for the record that this bill is SB 464, Healing Arts Self-Reporting Tools. And if you would just give us a brief summary, and then we will move quickly forward.
Self-reporting tools are used every day to help healthcare professionals collect data information like questionnaires you fill out whether you first see a doctor. These tools are used to collect information like family history, medical history, and substance abuse. This bill would allow patients to self-report the medical information when using mobile app access care. Mobile apps have the potential to transform healthcare by allowing doctors to diagnose and treat patients outside traditional healthcare settings, and I have a few individuals who would like to testify on behalf of the issue.
Yes. In support?
Quickly, California Medical Association. Support of the bill.
Yes. We have someone at the table that's going to speak first. Are you guys just
Oh, is
here to
that
go
okay?
to lunch? Yeah. Are you in support?
Yes. I was
Okay.
I guess.
Please.
Okay. So I just thank you for having me. I'm Dr. Melissa Chen. I'm an OBGYN and family planning specialist at the University of California, Davis Department of OBGYN, which is a leading department in the field of contraception. And as a specialist, I'm acutely aware of the consequences of unintended pregnancy. And I also know that contraception can significantly decrease the risk of unintended pregnancy by almost tenfold compared to someone who's not using anything for contraception. That's why it's important to increase access to contraception, which is a primary care service. In support of SB 464 will allow continued expansion of contraceptive services by breaking down barriers to access. So just as women currently self-report their medical history, I believe that they can also self-report their height, weight, and blood pressure. And this bill clarifies that patient-reported health care information is important and encourages people to take a more active role in their own health care. Self-administered hormonal contraception is the most common type of contraception that's used by U.S. women today, and these methods are safe. Concerns over hormonal contraception usually center around the risk of venous thromboembolism, which is clots in the legs or in the lung, and in young, healthy women, this risk is very low. So in fact, the risk of clots is lower in women that are in young, healthy women using hormonal contraception than it is for them when they are pregnant or after delivery by 2 to 6 times. 51% of pregnancies in the U.S. are unintended, and unintended pregnancy is a major public health problem here. And policies that break down barriers to access, such as SB 464, will help allow for innovative solutions to help address this problem. California is a leader in advocating for women's and men's reproductive health, and I think that this is another way that we can continue to improve health care for California citizens.
Thank you.
Thank you.
Others in support?
I'm Beth Parker. I'm the Chief Legal Counsel for Planned Parenthood Affiliates of California. And given the time, I won't do my testimony, but can answer questions, and we ask for your aye vote.
Thank you. Others in support?
Jody Hicks with the California Academy of Family Physicians in support.
Thank you.
Dr. Bonnie Zell, Board Certified OBGYN representing Icebreaker Health in support.
Thank you.
Dr. Juliana Mello, University of California, Davis in support.
Thank you.
Amy Durbin with the California Medical Association in support.
Great. Anyone in opposition?
Doug Chiappetta, Union of American Physicians and Dentists with AFSCME. We've had some clarification on the bill, so we are removing our opposition today. Thank you.
Thank you. We had a motion and a second. Any questions? Seeing none, we'll take roll. Do pass to appropriations.
Bonilla.
Aye.
Bonilla, aye. Jones.
Aye.
Jones, aye. Baker.
Aye.
Baker, aye. Bloom.
Aye.
Bloom, aye. Campos. Campos, aye. Chang.
Aye.
Chang, aye. Dodd. Dodd, aye. Eggman. Eggman, aye. Gatto. Gatto, aye. Holden.
Aye.
Holden, aye. Mullen.
Aye.
Mullen, I. Ting. Ting, I. Wilk.
Yes.
Wilk, I. Wood. Wood, I.
14 to 0. It's out.
Thank you, Madam Chair.
Thank you. We'll now add on for those members who were not present. We have 2 items that we'll start with on call. Item number 1, SB 270, Mendoza. Please call the absent members.
Bonilla.
Aye.
Bonilla, I. Chang. Dodd. No. Dodd, no. Holden.
Not voting.
Holden, not voting.
I was moving from not voting to a yes.
Ting, not voting to an aye. Eggman, not voting to an aye.
It's 6 to 6. It fails passage. He asked for reconsideration. Senator Mendoza did, so we will grant that. All right. The next item on call is item number 5, SB 538 by Senator Block.
Bloom.
Thank you. I just want to, if I might, make a brief statement because my vote was recorded as a no.
Not voting.
It was recorded as not voting, but I had actually voted no. I am content to leave after. Now I've had a lot of time to think about it, and I'm okay with not voting. So we'll leave it as not voting.
Bloom, not voting.
Okay.
Campos. Campos, not voting. Holden.
Yes.
Holden, aye.
Mullen not voting to aye.
Mullen, not voting to an aye.
Eight to 4 measures out.
8 to 4. The measure is out. And now other add-ons. This is SB 407. Morrell?
Bonilla.
Aye.
Bonilla, aye. Campos. Campos, aye. Dodd. Dodd, aye. Gatto.
Yes.
Gatto, aye. Holden.
Aye.
Holden, aye. Ting.
Aye.
Ting, aye. Because it failed passage, I don't think I can add you.
So am I just not voting?
Yes,
And then,
absent.
And then, did we get everybody?
Yes.
Done?
Okay, so
Everyone.
that's I can't add on to the.
Yeah.
Because it failed passage.
It's not in there.
Oh, okay, whatever. And then absence fine. Abstain fine. No is fine. Whatever.
But he can still vote. He can still vote. Did you, I mean, I haven't closed, the meeting's not adjourned. He can change his vote or whatever.
And no vote means yeah.
Okay. With that, we'll adjourn the meeting. Everyone voted, right? Huh?